Hello and welcome to another epic rehab video lesson on how to recognize and develop the value in each of us. I'm Dr. Leonard Matheson. My talk today was presented at the North American Spine Society 2017 meeting in Orlando, Florida, as part of a panel. My focus was how to connect assessment of biopsychosocial risk factors with treatment implementation in people with low back pain. My background at the Washington University School of Medicine has provided me with a front row seat on studies of the developing brain and more recently the human connectome. We are wonderfully integrated beings with neuroplasticity that sometimes causes problems. Now, the biopsychosocial model was a good point of departure from the strictly biological models of the early 20th century, but the 21st century requires expansion of the model, driven by neuroscience. As the psychologist on today's panel, my assignment is to help you implement biopsychosocial risk screening of your patients with low back pain. This will be a setup for the panel to get into specifics about treatment. I'm going to assume that most of you are siloed in unidisciplinary practices without the opportunity to consult a psychologist. I will address today's assignment by starting with a contextual model that I find useful when I work with people chronically disabled by pain. We'll start by taking a peek at our patient's biopsychosocial journey that causes them so much misery. This is where it stood at the turn of the century. It begins with a soft tissue insult that precipitates nociception, that if it's not handled properly, leads to localized impairment, which can receive a variable psychological interpretation which, if it's not handled properly, creates more generalized functional limitations that can spiral out of control and create major socioeconomic consequences for the patient and for society. And now we understand that the psychological interpretation eventually causes a neurobehavioral maladaptation in which neuroplasticity and neural epigenesis are harnessed to instantiate chronic neuropathic pain. When the patient ruminates and retreats from the pain, neuronal sensitization creates neural networks devoted to pain so that the nociception becomes less relevant. Impairment gradually worsens, which worsens neurobehavioral maladaptation. And as the impairment worsens, the patient retreats from normal activities of daily living, and functional limitations gradually increase, further worsening neurobehavioral maladaptation, with social isolation not far behind, leading to a growing sense of incompetence, helplessness, fear, and eventually clinical depression. Because chronic low back pain is essentially a neurobehavioral phenomenon, the biopsychosocial model continues to have relevance. But how did we actually develop the biopsychosocial approach to spinal pain rehabilitation? Well, many of its roots are found in the polio crisis of the mid-20th century. Vernon Nickel, a very innovative orthopedic surgeon, was having spectacular success fusing the spines of patients recovering from polio at Rancho Los Amigos Hospital in Downey, California. He invited a young man who had just completed his orthopedic residency to move to Rancho and get involved in rehabilitation. That young man was our late friend and colleague and mentor to many, Dr. Vert Mooney. In 1965, Vert joined Dr. Nickel at Rancho, where he began the work on chronic back pain that has attracted all of us here today. On the problem back service, Vert continued pay-it-forward mentoring when Tom Mayer became a resident. Tom eventually migrated to Dallas, where in 1977, Vert joined him and Bob Gatchell and Peter Politan and Nancy Cascino and a host of others, and here we are today. Next to Vert's picture, I have listed some of the people that he's mentored, and I'll point out that every single one of them is in a different profession. There are no duplicates. I had to leave dozens of people out, but you get the point that Vert's attitude about the scope of rehabilitation was expansive. But why was Vert's interdisciplinary personality so important? This is important for you to understand as we deal with neuropathic spinal pain. So let's go back briefly to Rancho. This is the stage model of rehabilitation that we developed at Rancho. No single discipline spans all 8 stages. It requires an interdisciplinary team. The Rancho model developed to help people severely disabled by polio, and then expanded to help people who were experiencing spinal cord injury, stroke, chronic pain, and a whole host of other severe disabilities. My experience tells me that it's necessary when we work with people with neuropathic spinal pain. As it turns out, the biopsychosocial journey and the Rancho interdisciplinary model map onto each other. But what do we do if we are siloed in our profession and don't have access to an interdisciplinary team? What if we are in a unidisciplinary practice? And the answer to that question harkens back to how we practiced at Rancho, as interdisciplinarians. We had loose discipline boundaries. Certainly, we respected each other's core expertise, but we helped each other learn what each of us were doing, with Dr. Mooney and Dr. Nickel leading the way. And so today, I'm going to share with you some of what a psychologist would do with a person who's disabled with chronic low back pain. I hope that you'll integrate some of these into your practice, no matter your profession. We need an excellent grasp of the biopsychosocial risk factors to guide our interventions. We need information about our patient's psychological interpretation of impairment, which is the root cause of neurobehavioral maladaptation. The Pain Disability Questionnaire is a great place to start. The PDQ gets at functional disability, measuring the daily life consequences of chronic pain. Using a visual analog scale from 0 to 10 over 15 items, the total score and 2 component scores predict return to work and retention at work. The PDQ provides 2 key pieces of information to plan my intervention: the PDQ function score and the patient's response to this question. Does your pain interfere with your ability to see the people who are important to you as much as you would like? The range is from no problems to I never see them. This item gets at social isolation and is thereby closely tied to depression, so I encourage you to ask it even if you don't use the PDQ. I find it very helpful. The next instrument that I recommend is the Fear Avoidance Component Scale. Pain has several affective components that magnify the consequences of impairment. Fear for immediate harm, anxiety about the future, psychophysiologic reactivity, depression and social isolation, anger towards self and others, are all components of diminished self-confidence that cripples self-efficacy. This is the briar patch from which few people escape and is a key motivator for opioid dependence recidivism. If this doesn't get handled properly as we wean people from analgesics, the weaning will fail. Although the total score has been demonstrated to have reliability and validity for predicting outcomes, I actually don't use the scores except as an aside. I am more impressed by the pattern of responses over the first 14 items. This helps me develop empathy and express concern for the misery experienced by my patient. The first 14 items give me a handle on how important learned helplessness is as a driver of clinical depression. The third instrument today is the Central Sensitization Inventory. My exposure at WashU to the default mode network and the human connectome, and Bob Gatchell's landmark 2007 paper in Psychological Bulletin, have led me to a new way of thinking about my work as a cognitive behavioral therapist. The neurological dynamics are rapidly being identified of the links between our patients' self-talk and the ability of their brains to support a return to high quality of life. I've become a much better cognitive behavioral therapist as I've integrated this exciting new information into my practice. In particular, I've developed a very strong bias toward helping people sleep well, a powerful driver of the first of the 4 factors in the CSI. Very few people with chronic pain do not have insomnia. The brain's ability to take care of itself, and thereby to take care of each of us, is intimately dependent on getting 5 sleep cycles in a 24-hour day. The ability of the prefrontal cortex to downregulate the limbic system is powerfully degraded by chronic insomnia. The final instrument I'll talk about today is the multidimensional task ability profile, which I use jointly with the EPIC lift capacity test when I conduct a functional capacity evaluation. I'll make it clear that I do benefit from royalties from these instruments, which I help to develop. Dr. Mooney was very interested in the integration of physical and psychological measures, and especially liked the idea of self-report measures that could be confirmed by observation. With his guidance at the U.S. Spine and Sport Foundation, we developed the MTAP to be cross-referenced with the EPIC lift capacity test. The MTAP was developed with item response theory techniques that allow mathematical comparisons among each of the responses on the 5-point scale to each of the 50 items in the test. This comparison of two MTAP items shows how a score of 2 on the first item makes it more probable that the same person will score 3 on the more demanding item. This comparison shows how a score of 3 on the less demanding item makes it most probable that the same person will score a 4 on the more demanding item. And this comparison shows how a score of 4 on the less demanding item makes it more probable that the same person will score a 5 on the more demanding item. And here's a profile of all 50 items, demonstrating variance from the most probable response pattern. These data are from a low back pain patient who's doing well in rehabilitation and really doesn't need an interdisciplinary approach. Two scores that quantify the variance from most probable are presented. The in-fit score and the out-fit score should be no greater than 1.50 if a person has a straightforward low back injury and has not developed neurobehavioral maladaptation. But here's the profile of a low back pain patient who's not doing well in rehabilitation and really needs an interdisciplinary approach. We see that the in-fit score and the out-fit score both exceed 1.50, which primes us to take a closer look. And we take a closer look by considering two sets of data. First, the self-report data that we've obtained through the questionnaires I just described, and second, we compare these responses to actual physical performance measures. Recall that we designed the MTAP to parallel the EPIC lift capacity test. By using age-based and gender-based normative data for both instruments that have been collected on the same 4,000 healthy normal subjects, discrepancies must be explained by the organic impairment, and then I partial out the patient's psychological interpretation. To wrap up, we've left behind the curative impairment model with the too often false assumption that the patient's psychological interpretation accurately maps onto the impairment, and if we minimize the impairment, we minimize the dysfunction. The biopsychosocial model helps us to appreciate the leverage we have to minimize dysfunction by helping the patient to develop a healthy, positive interpretation of the impairment and to negotiate with his or her pain symptoms so that the dysfunction is minimized. Neurobehavioral maladaptation with central sensitization is minimized or entirely avoided. Just as important, the biopsychosocial model helps us to appreciate how ignoring or mishandling the patient's interpretation of the impairment can magnify the dysfunction and create a neurobehavioral maladaptation that is represented in neuropathic central nervous system pathways. And so as a psychologist, I'm looping back to how we need to do a better job handling the psychological interpretation to avoid neurobehavioral maladaptation. I use a cognitive behavioral therapy approach informed by neuroscience, with a strong emphasis on cognitive behavior therapy for insomnia. Here are the resources for the instruments that I presented today. The PDQ, FACS, and CSRI are available at no cost from the Pride Foundation. A no-cost MTAP online trial can be arranged by contacting the Vert Mooney Research Foundation. Information about licensure and training for the EPIC lift capacity test is available through EPIC Rehab. Now I'd like you to leave Orlando with something tangible you can use next Monday. I'm happy to provide a CBT insomnia resource I've developed for my patients with chronic pain. Called Brain Restorative Sleep Guidelines, it's the latest in sleep research and very useful. If you subscribe to this channel and then drop me a note, I'll get a free PDF back to you. Thanks very much for your attention. Take care now.